If you look at why patients aren't undergoing bariatric surgery, you can see I'm focusing on some of these factors here, but basically it's based off of fear. So there's fear of complications, fear of dying. So 25% of patients are afraid of dying on the table or immediately thereafter, maybe out of proportionate to the actual risk of the procedure, but there certainly is a lot of fear, and then of course cost, pain, and other issues. So patients aren't willing to undergo these operations for a variety of reasons. And so, as they like to say in the VC world, there's an unmet need for a minimally invasive treatment option. Only about 1% of patients who qualify for bariatric surgery are actually getting it, right? So these patients are sort of limited in their options. All right, so this is where endoscopy can kind of fill in this role. And so why the endoscopic approach? So I call it the 99%. So these are the 99% of folks who aren't qualifying or aren't undergoing bariatric surgery. We have vulnerable populations. We have lower BMI patients who don't qualify for bariatric surgery. Medications are available, but with limited efficacy and questionable insurance coverage, so they're not great. And we know surgery is invasive and expensive and so forth. And there's a patient demand. They want something minimally invasive, no scars for cosmesis, something that can be reversible, particularly in adolescents. So there's a lot of appeal to an endoscopic approach. Another way I put this argument is looking at some other fields in medicine. So we look at cardiology. When you're treating a patient with heart disease, you treat them with exercise, diet, and medications. If that doesn't work, you go to your minimally invasive option of angioplasty, and then you go on to your CABG if that doesn't work. Same with orthopedics. So you have exercise, PT, and medications, arthroscopy to clean out a joint, and then you go to the total joint replacement eventually. In obesity, you have exercise, diet, and meds that don't work very well, and then you have surgery, but we don't have that middle option. And again, this is where endoscopy nicely fits into this paradigm. Again, put another way, if we look at effectiveness on the x-axis and risk on the y, you can see diet and exercise, low risk but low efficacy. We have surgeries over here. Again, endoscopy is going to sit right in the middle. Okay, so this is where the logic behind endoscopic bariatrics comes from. When we look at these technologies and how we evaluate them, the ASG and ASMBS got together and put out this PIVI document looking at what our goal should be and our standards for evaluating new bariatric therapies. To summarize, we're looking at least a 25% excess weight loss at 12 months. That's sort of our general threshold we're looking for. It should have a greater than 15% excess weight loss compared to placebo or control groups. There should be a less than 5% incident of serious adverse events. And these are sort of the standards by which we're judging these therapies going forward. All right. When we look at total weight loss, so if we summarize lifestyle interventions, 3 to 5% total body weight loss, medications 5 to 10, 10% of total body weight loss is sort of that magic number where we actually see reversal of comorbid conditions, improvement of metabolic health. So 10% total body weight loss is something that comes up often when we talk about endoscopic bariatric therapies, and that's where these tend to fall. So what do we have now? So I'm going to divide these into gastric therapies and small bowel therapies. So in terms of gastric therapies, we have our balloon products here. This is the Reshape Duo balloon. So there's 2 balloons that you place into the stomach endoscopically. These are filled independently. The idea behind this is that if one deflates, the other stays up, so we don't have balloon migration, and you still have efficacy. This is the Orbera intragastric balloon. This used to be known as the BioEnterix intragastric balloon that's been around for decades. It's got rebranded, bought by Apollo Endosurgery as Orbera, single fluid-filled balloon, again, placed endoscopically. Both these balloons, you place them endoscopically and then you remove them endoscopically at 6 months. So they're approved for 6-month implantation. This is the Obalon balloon system. This is actually a gas-filled balloon. The advantage here is that you actually you can place the balloons in the office, so it's a capsule essentially on a string. The patient swallows it with a glass of water. The capsule gets into the stomach. You confirm on fluoroscopy that the capsule is actually in the stomach. They have proprietary nitrogen gas cartridges. You hook it up to the balloon on the catheter, and then it inflates the balloon in the office. So theoretically, this could be performed in primary care offices as well. You can place multiple balloons with this technology, so you place a series of balloons over several months. The absolute weight loss is less than these 2, but tolerability may be a little bit better. So these are the 3 approved balloon options. Then we have the Spatz adjustable balloon. So this is a balloon we place. You can see this little catheter here. You actually drop that into the stomach. You can actually go back in endoscopically and adjust the balloon volume for tolerability or to enhance weight loss. And I'm going to cover an abstract that was discussed at DDW this year. Pivotal FDA trial is underway right now. And then lastly, we have the Ellipse balloon. So this is now a totally procedureless balloon. So it's an existential threat to our business. But essentially, it's a balloon that, again, it's a capsule on a string. You take it in the office, you inflate it, and then this sort of area here catastrophically ruptures. At about 12 weeks, and actually the balloon spontaneously deflates, and then you pass it in your stool. So totally procedureless balloon technology. They've have their trial underway as well. They've had some issues with the balloon, actually deflated balloon getting caught up in the small bowel, so there's some issues with it, but very interesting technology that's coming forward. Next in our gastric therapies, we have aspiration therapy. It's exactly what it looks like. So this is a large caliber, low profile G tube that you place in the stomach. The patient has this sort of catheter device set up, so you place the G tube, they have their meal, then they go to the bathroom and they lavage essentially out their ingested calories. They lose about 30% of their calories per meal. This always gets a rumble from the crowd when we see this because we like to call this medical bulimia in its worst form. But it works. It's FDA cleared. It actually works. It's actually the most robust in terms of absolute weight loss of all the endoscopic bariatric technologies. So it works. Particularly for the higher BMI folks who don't worry about cosmetics and so forth, and they may not be great candidates for surgery, could be an option. So we can judge, but it's available. Next, we have plication devices. This is the POSE procedure. You perform it with something called the incisionless operating platform. It's actually essentially an overtube system that goes down to the stomach, and you're placing nitinol anchors in the stomach to sort of crimp the mucosa. It's essentially full thickness, and it can reduce the volume and capacity of the stomach. They just completed their multi-center US trial. Actually did not meet endpoints. And then we have endoscopic sleeve gastroplasty. So this is using the Apollo overstitch suturing device. You make full thickness plications, and I'll get into this more later in the talk. That's also approved. In terms of small bowel therapies, we have endobarrier, which is essentially an implanted sleeve that goes through the duodenum, trying to reduce nutrient exposure to the duodenal mucosa, and actually induces changes in glucose metabolism in the liver. They actually had their pivotal US trial stopped early due to a rate of liver abscesses, probably from these nitinol anchors here in the duodenal bulb, so they're redesigning that product. We have Revita DMR, which is duodenal mucosal resurfacing. And I'm going to touch on this more later because it's a very intriguing idea. Another sleeve by Valentix. And then we have the incisionless anastomotic system where actually two magnets can be placed endoscopically with two scopes. And then they fuse together to create actually either a gastrojejunectomy or jejunal-ileostomy, whatever you like to create. And it's actually a very clean anastomosis because it's just magnetic. And the body takes care of the anastomosis, no suture. So very intriguing. And the first in-man study was published last year out of Czechoslovakia. All right, so that's our summary. So let's talk about some of these technologies in more detail. So intragastric balloons, to summarize the data to date, when we compare the intragastric balloon to control groups with diet and lifestyle intervention, we're reaching about a 25% excess weight loss. Like we summarized previously, that's our goal, and greater than 15% over control groups. If you just look at Orbera and the history of the Bioenterics balloon, if you look at all the publications, there's been over 230 publications, over 8,000 patients. You can look at a mean excess weight loss of 15 pounds, pretty robust results here with respect to excess weight loss and BMI, and importantly, improvements in measures of comorbid illnesses. So these therapies are effective. Now, some of you may have seen this. I don't know if you caught this in your emails from the societies, but there were a couple of emails that went out from the FDA and alerts looking at deaths associated with the balloons. So there have been 12 deaths reported from the intragastric balloon in the US since 2016. I'm sorry, worldwide, 7 in the US. It's been hard to sort of track down what exactly happened. I know of at least 4 perforations related to the balloons. There's a couple episodes of pancreatitis as well, and it's not clear why they developed that pancreatitis. The theory is perhaps you have this large bezoar in the stomach and they're putting pressure on the pancreatic tail. It's not really clear. Anyway, and these have occurred with both the Reshape and the Orbera balloons. So this caused a lot of negative press associated with these technologies. But it's important to remember that when we summarize all of the implants worldwide, still the global rate of occurrence of serious adverse events and death is less than 0.01%. So they're still very safe. So what I take away from this is that they're still very safe, but you're still putting in a foreign body in a patient. And we still have to follow these patients carefully and be vigilant for adverse events. So we know balloons work. So now we're starting to look at intragastric balloons for NAFLD and NASH. I use this slide as sort of a predecessor to, and I don't know if Mustafa is going to cover this in his talk, but there's really a push in endoscopy to look at sort of endoscopy for the liver. So we have a precedent now. We're doing portal venous pressure measurements. There's 25 gauge needles using a manometer here, and there have been a few presentations at DW on that. We're already doing glue coil injection into gastric varices. And we're also doing liver biopsies now using EOS guidance. So if a patient needs an endoscopy for whatever reason, variceal screening, we can put an EOS scope down, do a liver biopsy under real-time ultrasound guidance, and it's very safe and effective in terms of getting adequate triads. So there's a big focus now in interventional endoscopy looking at the liver, and balloons are no different. So this was a trial actually done out of China in 2012. It didn't get a lot of press, but I think it's a very intriguing idea. So this was a randomized controlled single-blinded trial. They had two groups. So they had one group on diet and exercise and a sham endoscopy, and then diet and exercise and the bioenterics balloon, or now known as Orbera. They included a total of just 18 patients with a BMI of greater than 27, NASH histology on liver biopsy within 6 months of their procedure. They removed the balloon at 6 months and then repeated the liver biopsies. So biopsies before and after, we have histology at both time points. If you look at just BMI between the treatment and control groups, there's a significant reduction in BMI compared with control, which we would expect all the same. And then we look at activity score. Again, there was a significant reduction in activity score in those patients who were achieving weight loss with the balloon compared to the control group. So interesting idea. They didn't really follow, this group didn't follow this up with very much after that. But again, intriguing concept for our NAFLD NASH patients. Now, this was an abstract presented at DDW this year, sort of a similar study here, where they had 21 patients with NASH by MR elastography, and then they actually did an EOS-guided liver biopsy at the time of balloon placement and also at removal. And again, so in terms of total body weight loss, about 13%, significant reduction in hemoglobin A1C as well, and decrease in waist circumference. If you look at radiologic measures of activity in NASH, there were significant reductions in both measurements. And if you look at activity score, they decreased with a median decrease of 3 points in the patients, in the majority of the patients. 73% achieved a 2-point reduction. And all patients with early fibrosis actually regressed. So again, an intriguing concept that we can actually treat some of these patients with endoscopy, let alone some of these medications that were discussed earlier. So another idea that was discussed at DDW is this concept of how do we predict how patients are going to tolerate the balloon and who's going to respond and who's actually going to lose weight. These are just example pictures of a balloon sitting in the stomach here in the fundus on retroflexion. Here's a CT image of the balloon. We're putting in this giant bezoar essentially in the stomach. We're just dropping it in instantly into someone's stomach. It's about 500 cc's of fluid, right? So this can cause a significant amount of symptoms. So we're trying to figure out, okay, so how can we sort of help patients adapt to this, and who can we predict is going to tolerate it going forward? So by putting in this bezoar, so this is a meta-analysis looking at over 8,500 patients who get the single fluid-filled balloon. You can see a high rate of pain and nausea, particularly within the first week, and a 7.5% rate of early removal due to intolerance. So, and I should add that these procedures are not covered by insurance yet, and so these are cash payment procedures, anywhere from $6,000 to $10,000, depending on where you live. So having an early removal really is a significant adverse event for the patient, not for their health, but also for their wallet, right? So we have to prevent this at all costs through medications and so forth. So the idea is, how can we predict this? So this was an abstract presented by Bahram Abadiah's group from the Mayo, and they included 32 patients getting the Orbera balloon, and they were trying to evaluate whether gastric emptying studies would actually predict who's going to tolerate the balloon and how are they going to respond to it. So they performed gastric emptying studies at baseline and then 3 months after they got the balloon. And essentially what they found was that a delay in gastric emptying at 3 months, so in other words, if we induce delayed gastric emptying by putting the balloon in, it increases the patient's weight loss. So essentially we put in this bezoar, delays gastric emptying, increases satiety, and patients are going to lose weight. If you look at responder rates as defined by patients who achieved at least 10% total body weight loss, again, that's our threshold we're trying to achieve. Those who didn't experience any delay in gastric emptying, only 20% achieved that threshold, whereas 80% did, and those who actually achieved gastric emptying. So we're trying to induce essentially gastroparesis in these patients, and so they can achieve weight loss. In terms of tolerability, if you looked at the patients at baseline who had slower gastric emptying, so people in the slowest gastric emptying quartile at baseline, they had a 5 times higher likelihood of having the balloon removed. So you took a patient with dysmotility, you put a bezoar in there, and what do you think is going to happen? They're going to feel a whole lot worse, and they're not going to tolerate the balloon. So they propose that if we actually do a gastric emptying study beforehand, before we insert these balloons, we can maybe predict who's not going to tolerate the balloon and avoid 75% of these early removals, and again, improve outcomes for patients and improve outcomes for their wallet as well. So that's an interesting idea. But of course, in that case, we're doing gastric emptying studies and doing scintigraphy. It's another test that the patient has to go to. So another group actually looked at this office-based gastric emptying study. So this is from Cairn Diagnostics. It's actually carbon-13 labeled spirulina. and it's actually a gastric emptying breath test that you can do, and essentially it's a point of care test that you can do in the office. So even beyond balloons, I think this is an intriguing idea for all of us as gastroenterologists that this may actually work. But again, they had the same idea that can we do this at point of care and predict who's going to respond to this? So they had 18 patients undergoing Obera balloon placement. They did this breath test as well as a Ensure satiety test looking at maximum tolerated volume before and after the balloon placed. Again, great total body weight loss of 16%. The time to emptying increased in all their patients who got the Obera balloon. They had a decrease in maximum tolerated volume, which again would make sense. And again, a delay in gastric emptying at 3 months significantly correlated with total body weight loss. So again, we're trying to induce sort of gastroparesis in these patients, and sort of an interesting concept to understand why these balloons are actually working. Okay, and when they compared this, the ROC curve compared to scintigraphy, their breath test actually was not inferior, if not maybe superior to regular scintigraphy. So an interesting idea. So next we have an adjustable balloon. This is a balloon. This is called the Spatz balloon. So as I mentioned earlier, so this is a balloon placement. We place it endoscopically. This can be filled with a variable amount, typically around 600 cc's. You drop the balloon in, and then you disconnect this catheter, and the catheter essentially falls into the stomach and stays there. As you can imagine, with a typical Obera or V-shaped duo balloon, they're a nice, perfect sphere, a little bit better tolerated, you'd imagine. With this sort of catheter hanging in there, this could lead to issues. And one of the issues that we're concerned about is maybe this is going to go through the pylorus and create pressure either at the pylorus or at the incisura and lead to gastric ulceration. And there is a small rate of ulceration with these balloons. So this is an interesting study. So it's a great concept. Can we adjust the balloon, improve tolerability and improve weight loss? So this was a large study out of Brazil looking at 487 patients who were prospectively enrolled in this trial. They filled the balloon to 600 cc's at baseline, and then they would adjust as needed based on symptoms. So if they had a lot of nausea and pain and they wanted it removed, we'll adjust the balloon and decrease the volume. Or if they're not achieving weight loss goals, they'll increase the volume. And so what they found was 11% of the patients actually did require down titration of the balloon volume, and all of them tolerated this, and none of the balloons were removed, so that's good. So we can keep the balloon in the patient when you down titrate the volume by about 300 cc's. And you can see about 4% of these patients actually had developed ulcers, but they didn't require balloon removal. They were just treated with PPI, and they actually were able to essentially play through and do fine. In terms of upward adjustment, so 232 patients needed upward adjustment and 205 without. If you compare the two groups, essentially they had the same total body weight loss, same reduction in BMI of about 7 points, and same 64% excess weight loss, which is actually quite robust, which is nice to see. So essentially what I take away from this is that with this balloon, downward adjustment does improve the tolerability of it, but upward adjustment actually doesn't enhance weight loss. And I suspect that once we have the BZOR in there, putting more volume in there is not going to enhance the effects in terms of activating stretch receptors and satiety. All right, so switching gears to remodeling devices, I'm going to discuss endoscopic sleeve gastroplasty. So this uses the Apollo Overstitch device. It creates full thickness plications in the body of the stomach. So we're not addressing the anterior, and we're not addressing the fundus. And this, just to walk through the stitch pattern here, this is what it looks like. We're placing plications in a distal to proximal fashion like so. And we're essentially, it's almost similar to surgical imbrication. So we're reducing the volume of the body of the stomach. Here's an example patient. I did, let's see if it plays. So essentially what we start out with, we use APC to mark out the anterior and posterior borders of the stomach like so. And then we're going to place our applications like this in a distal to proximal fashion. So I'll come back here. So this is the suturing device. Again, you need a 2T scope for now. They're creating a single channel device that's forthcoming, and they did receive clearance for that. But for now, we need a 2-channel scope. We're putting in 2 Oprolene sutures here. And essentially what we do is, as we take our bites, we're using tissue helix, which is essentially a corkscrew. And we corkscrew into the tissue here with this device. And we're going to bring the tissue in, and the goal is to actually get full thickness bites and get serosal bites to increase the durability of the procedure. The advantage, again, this is an outpatient procedure, come and go. So it takes about an hour and a half to complete the procedure, all told. I'm just going to move ahead for the sake of time. But there's sort of the first series of bites. And we're using this catheter to cinch off the suture. So that's what it looks like from the first bite. So you can see a nice sort of crimping together of those folds. And then as we come to the end here, this is what it looks like at the end, immediately post. I'm insufflating air, but you can see there's really no capacitance in the stomach. We're reducing the capacitance of the body. Again, we don't actually address the fundus, and the reason being is that in early trials, we're seeing a high rate of abscess formation, perigastric abscess, splenic injury, even with this procedure. It's important to note, too, that this procedure, and here's a nice view of upper GIs afterwards. Here you can see a nice reduction in the size of the body. When you look at scintigraphy in this procedure, it's actually decreasing gastric emptying, similar to the balloon. So we're leaving the fundic reservoir, and they're having patients experience increased satiety with decreased emptying. Now, that's the opposite of a surgical sleeve. It actually decreases emptying time. So it's actually a different mechanism of action. If we look at the studies to date, there have been 3 multi-center studies, including over 500 patients. To summarize, we're looking at about 15 to 20% total body weight loss across the board. Our longest follow-up is now to 2 years, and that weight loss is sustained to 2 years so far. So how does it perform? So we know we can lose weight, but what about metabolic parameters? This is a study published by Reem Sharia's group out of Cornell. Single center study of 91 patients. They experienced 20% total body weight loss, and importantly, they found significant reductions in A1C, blood pressure, circumference, ALT levels, and serum triglycerides. So again, we're improving metabolic disease, not just weight loss. It's important. She went on actually to publish the second study a year later, actually comparing ESG with lap sleeve gastrectomy and adjustable gastric band. Those were performed by the surgeon. She's a gastroenterologist. But if you look across the board in terms of total body weight loss, of course, the sleeve gastrectomy was superior, but interestingly, ESG was superior to lap band. I don't know if anyone's really performing that procedure anymore, but ESG does outperform lap band in that regard. Morbidity was much less with the endoscopic approach. In fact, the only significant morbidity that patients had to be admitted for was a migraine. And then one patient actually ate a burger within the first week after getting the procedure, developed a leak, and developed issues with that needed percutaneous drainage. But as you can see here also, these patients are come and go the same day. So it's actually very cost effective in terms from a health system standpoint in terms of getting robust weight loss here. All right, so what about health-related quality of life? This is an abstract presented this year out of Lopez Navas' group out of Madrid. This is 107 patients treated with intragastric balloon and ESG, looking at the short form 36 at 8 to 12 months of follow-up. As you'd imagine, as these patients lose weight across the board in terms of physical and both mental domains, there were significant improvements overall. And then when we look at actually absolute weight loss, we're comparing less than 10%, 10 to 20, and greater than 20% total body weight loss. You can see there's significant improvement in physical functioning change, and in the mental domain in health transition change and mental summary. So a little bit intuitive, but it's nice to actually get some objective data showing that not only do these procedures improve metabolic parameters, but also patients' quality of life. So here's a video of another technology here. This is called Indomina. So this is a endoscopic suturing device. As an aside, interestingly, in endoscopic technology, what we're seeing now is that more devices are going around the scope rather than through, and it's actually improving our abilities here. So this actually clamps onto the scope, and you can actually pass a T-tag through. It might be hard to see in the back of the room, but essentially you're passing a needle and then a T-tag through, almost like a push bag from Kimberly-Clark, where you pass a T-tag like so. And that way we can actually perform full-thickness plications in the GI tract that way. And the same idea here is you're trying to imbricate the greater curvature of the stomach, doing serosal to serosal apposition. This is what it looks like endoscopically. These are the data that they presented, including a total of 51 patients with a small rate of recidivism. You can see the weight loss is really not quite as robust as with the ESG procedure using the Apollo overstitch. I think my concern with this is that we're actually not getting full thickness with these plications. So pretty modest weight loss, interesting idea, but I think we need more data on this. This was a actual ASG plenary that was presented as well. So we have all these publications on each of these technologies, but nothing's actually compared one to the other. So this was a single center study out of Madrid looking at the Orbera, Reshape Duo, the ESG, and then the pose procedure, the plication procedure. This was a large study, including over 1,000 patients, 400 with the balloon, 300 with the sleeve, and then 230 with the pose procedure. 40% of the patients actually completed 1 year of follow-up, so it should be noted there was a significant recidivism. But to cut to the chase, across the board, total body weight loss was comparable between all the technologies, so none actually outperformed the others. And when we look at responder rates, so when we're looking at our thresholds, remember the total body weight loss greater than 10% is what we're looking for. About 3 out of 4 patients were able to at least achieve that goal. So these endoscopic technologies are working to achieve this goal. About a third of the patients actually got to greater than 20%. An important takeaway that from this study that has been reinforced previously in the literature, but I should mention again, is that when you look at percent total body weight loss and the number of contacts that the patient have with the healthcare team, there's a significant increase in total body weight loss with the number of contacts with the healthcare team. It's intuitive, but it's really important, especially if any of you are interested in developing bariatric practices. It's important to have a robust infrastructure that these patients actually meet with the team over time. All right, to conclude in the last about 5 minutes, I'm going to talk about small bowel therapies here. So this is an interesting area now that's developed quite rapidly in the last couple of years. So again, I mentioned that there's this idea of the foregut hypothesis, and we know anecdotally when patients undergo gastric bypass surgery, their diabetes improves the next day, right, without actual weight loss. So there's some concept where we're bypassing the duodenum that's creating metabolic change and most likely occurring with hepatic insulin resistance. And we know that patients on Western diets who are obese have altered mucosal hyperplasia in the duodenum and altered signaling of endocrine pathways. It's not well developed yet in terms of the pathophysiology, but it certainly exists, and we've seen proof of concept in the surgical field. So now this has become a focus in the endoscopic field as well, okay, particularly with a focus on type 2 diabetes and NAFLD. The technology I'm going to mention here is called duodenal mucosal resurfacing. I think it's a really neat idea. And this was developed out of the Brigham by a cardiologist, in fact. But the idea here is that we're actually going to perform ablation of the duodenal mucosa using hot water infusion. So what you do is you mark the papilla so you don't actually burn the papilla and cause pancreatitis. They put this proprietary catheter down, and it actually has these suction areas, and you suck up the mucosa. It has a needle that you advance, and you actually create a submucosal cushion. Right, so that's analogous to an EMR. We're trying to protect the deeper layers and prevent scar formation. All right, so then once we make our lift, that's what it looks like endoscopically, and they use a little bit of methylene blue dye. Then they put down the ablation catheter, and essentially you're instilling hot water to ablate the mucosa. So you can think of an analogy in Barrett's RF ablation, the same idea, but we're actually doing it with hot water. And the idea here is that you're just going to ablate the surface epithelium and somehow magically reset it back to normal, again, similar to Barrett's esophagus, and you're going to see improved metabolic parameters. All right, so very interesting idea. This is what it looks like in the pre-procedure duodenum. You ablate, you see a little bit of edema there, 1 month follow-up, and then at 3 months, it actually looks the same. So you actually have reepithelialization with normal epithelium. So 2 multi-center studies were actually presented at DDW. I'm just going to whisk through in the last couple of minutes. This is the Revita 2 study. It's a multi-center RCT. This was data presented from their open label lead-in phase, actually the training phase for the endoscopist. They included 24 patients with diabetes times 8 years. They kept their medication stable in the preceding 6 months. If you're looking at 12-week follow-up, there was a significant reduction in hemoglobin A1C with really a non-significant reduction in weight. So again, this is improvement in metabolic parameters without alteration in weight. If you look at the remainder of the metabolic indices, looking at A1C, fasting plasma glucose, and so forth across the board, you can see significant reductions across the board without really large weight loss from the procedure. So again, this is somehow altering metabolic signaling from the duodenum. Very interesting idea. No significant adverse events, no strictures. They also presented the Revita 1 study with longer-term follow-up. So this is the original safety, efficacy, and dosimetry study. They completed the DMR in 37 of 47 patients, so 3/4 of the patients, successfully in 9 to 10 centimeters of length of the duodenum. They only had 1 significant adverse event. A patient developed fever and elevated CRP, but they were discharged the next day. And again, across the board, significant reductions in A1C, HOMA-IR model of insulin resistance, fasting glucose, and interestingly, again, liver enzymes as a proxy for fatty liver disease, ALT and AST, there were significant reductions in those patients and more pronounced in patients in the higher tertiles. So again, it's sort of an intriguing idea. So what's interesting about this technology is, again, we're not focusing on weight loss, we're focusing on metabolic disease and hepatic insulin resistance. And as Nora and I were talking about, I think some of these technologies are very interesting in terms of treating NAFLD and NASH specifically, not necessarily for weight loss, but improving hepatic insulin resistance here. I'll conclude on a somewhat comical note. This is actually a device that is real. It's presented at the European Congress of Obesity. It's marketed as the NOS device. This is actually a device that you insert in your nose. These are two sort of implants here, and you stick them in your nose. And it's not being marketed as a medical device. It's just sort of off-the-shelf product, so you can probably get it at Walgreens someday. They market it as it inhibits smell without compromising breathing somehow. So it's a wellness device. And their initial study was in 65 obese patients. They saw significant reductions in weight compared with control patients, reduced insulin levels, blah, blah, blah. But it's sort of an interesting idea, and it also shows where we are in terms of the obesity epidemic and what we're actually doing. So if we saw the aspiration therapy that's FDA cleared, we're seeing these types of devices. So it's a huge problem, huge space for us to develop, and I really do feel that as a gastroenterologist, it's important for us to be there. So to conclude, so endoscopic bariatric therapies are established as a viable weight loss or metabolic therapy. I think we're beyond the idea of saying that, well, they're sort of interesting, but they don't work. We have well-established data now that they do work, both for weight loss and metabolic improvements. It's important to only perform these as a multidisciplinary approach, and I think that's been the struggle as a gastroenterologist to develop that team. I think you need endocrinologists, you need dietarian, you need your surgeons to help back you up as well. So DMR, adjustable balloons, implication devices, and other small bowel therapies are coming soon, probably in the next couple of years. I'm really excited about getting my hands on those as well. And what we're starting to look for now is sort of an area of tailored therapies. So we pick a patient, someone who's obese, and we say, do you need a small bowel therapy? Do you need a gastric therapy? Do we need a combination thereof? I think that's the era now that we're moving into in the future, so it's pretty exciting. So thanks for your attention.
Thanks, Rabindra. So we're going to swap out computers here, so I think we can